Good day, everyone. Welcome to this Goodfellow Unit Webinar tonight on the modern pathways in prostate cancer investigation and management. This webinar is kindly supported by Mercy Ascot. We're very lucky to have three speakers this evening. Andrew Lienert, a urologist specialising in laparoscopic uro-oncology and kidney stone surgery. Andrew Williams, a urologist with subspecialist training in robotics and complex cancer surgery, and Remy Lim, a specialist radiologist in oncology and genitourinary imaging. So we're really looking forward to hearing from all three of our speakers tonight. Now, I think Andrew Lienert is going to be our first speaker this evening, so I will let you go for it, Andrew.
Thank you, Helen. So thank you. I'd also like to reiterate a thank you to Mercy Ascot for sponsoring this, and also the Goodfellow Unit for facilitating this opportunity to speak. A modern prostate cancer pathway, like many cancer pathways, involves a number of stages, from testing through to biopsies to staging, treatment, and then just as important is looking after our patients following treatment. These pathways can take a long time. I reviewed the length of time it takes on average in the public hospital system here in Auckland, and what we found is it takes from referral from GP through to treatment was somewhere between 200 and 250 days. Even in the private system, in the group private practice that Andrew Williams and I work in, the average time will be around 100 days. We're grateful to be able to collaborate with both Southern Cross and Mercy Ascot on working on shortening that pathway with a 4-week target for referral to treatment for Southern Cross patients, which will be rolled out shortly. This talk's going to be a bit of a whirlwind. This is a very broad topic, and we'll be roughly going through the stages that I've listed there. I'll start off, and my colleagues will follow on with some of the other aspects. Why talk about prostate cancer? Well, it is a major cause of both mortality and morbidity in New Zealand men. Prostate cancer causes around 600 deaths per year. For comparison, breast cancer causes a very similar number of deaths per annum. It's estimated that prostate cancer is responsible for about 16% of cancer-related morbidity and mortality. Prostate cancer testing with PSA is, I'm sure you're all aware, is a very controversial topic, and one that's been discussed a lot over the last 15 or more years. I'm not going to go into the details of the controversy. What I wanted to do, though, was just highlight what I think are three definite facts about prostate cancer testing with PSA. And that is that prostate cancer testing does cause a reduction in prostate cancer mortality. It causes a reduction in late-stage metastatic disease. But on the flip side, it also leads to overtreatment and overdiagnosis. However, with modern diagnostic pathways and also modern both treatment protocols and treatments, there is a reduction, a significant reduction in the overtreatment and the morbidity of treatment, and also in the overdiagnosis. And I hope we'll be able to show some of that as we go through tonight. For reference, this is a graph of the prostate cancer mortality rates based on New Zealand data. You can see where PSA screening was introduced in the early to mid-90s, and since then there's been a steady reduction in prostate cancer mortality. Whilst not all of that will be due to the introduction of PSA testing, certainly PSA testing has had a significant influence on that reduction in mortality. PSA testing is very common. There is no official national screening program. However, a few years ago, a PhD student here in Auckland did an extensive research study on PSA testing, and as part of that found that over the decade between 2009 and 2019 in the northern region, so that's pretty much anywhere north of the Bombay Hills, that 87% of men aged between 40 and 70 had had at least one PSA test. There had been some earlier studies in other districts in New Zealand that showed much lower rates than that, but I think on the basis of that most current research, in a way, there's a form of ad hoc screening going on in New Zealand. One of the questions that arises, or controversies, isn't PSA a very inaccurate test? That is true if you're using PSA as a diagnostic tool for prostate cancer. So it has very high false positive and false negative rates for a diagnosis of prostate cancer. However, in my view, PSA should be thought more as a risk stratification tool to determine which men are at higher risk of prostate cancer, rather than viewing it as a tool for diagnosing prostate cancer. If you compare breast cancer screening to PSA testing, the numbers needed to screen, that is the number of men that you need to do a screening test on to save one life, and the numbers needed to treat, that's the number of men that you need to treat to save a life, are very similar if you compare it to breast cancer screening. There's a very strong correlation between PSA levels and risk of cancer. The graph that I've put up there is a summation of a number of meta-analyses looking at PSA levels compared to the probability of a high-grade significant prostate cancer. And you can see in all of those studies, the higher the PSA, the higher the risk that a man has cancer. Another question that arises is how often should we do a test? In my view, I think annually is a sensible number that's easy to implement. A lot of men are coming in for annual tests for other monitoring. The screening trials of PSA testing generally had intervals of either 2 years or 3 years, dependent on which trial or which country it was conducted in. However, there have been subsequent studies showing that a shorter interval between tests results in a further reduction in prostate cancer mortality. And so in my mind, an annual test is a good balance between not testing too frequently, but lowering the likelihood of missing something. I would suggest that if a man has a family history of either prostate cancer or breast cancer, that we start at age 40, otherwise at age 50. Another common question is a digital rectal examination necessary? And both in the New Zealand prostate cancer guidelines and also in my view, it's not necessary if it's going to be a barrier to actually getting a prostate test done. That barrier may be a patient barrier. A lot of patients, understandably, are very reluctant to undergo the examination. It may also be clinicians. You may not feel confident doing a digital rectal examination because you're not sure of exactly what you're feeling and whether you're going to miss something. If either of those are going to be a barrier, I would suggest just doing the test is absolutely fine. The reason that we do a digital rectal examination is that there are a number of prostate cancers that don't secrete PSA or secrete very little PSA. And men, a significant proportion of men can have prostate cancer even with very low PSA levels. And those non-secreting prostate cancers are often the more high-grade, poorly differentiated cancers. The only way that they will get picked up is either through presentation with symptoms that are investigated, or if we examine men and feel the cancer. We're talking about modern pathways, so what about new prostate cancer tests? Surely there must be something better. PSA has been around for nearly 30 years now. And there are a number of tests that have been developed, some based on genetics, some variations on PSA, and some are urine-based tests. However, in the New Zealand environment, the only two alternatives that we have available are either PSA density or free PSA. PSA density is just taking the PSA level and dividing it by the volume of the prostate. In essence, this helps to differentiate between men who have an elevated PSA because of significant benign hyperplasia of the prostate versus men who may have cancer. The only way you can calculate a PSA density is obviously to have a volume of the prostate, which you can get either from an examination, an ultrasound, or an MRI. Both an examination and an ultrasound are very inaccurate ways of determining prostate volume. And so, as I alluded to in one of the early slides, the next step in the diagnostic pathway is imaging, which is usually in the form of an MRI. And that's a very accurate way of determining volume and helping to measure PSA density. Free PSA is a variation on PSA that's available as a blood test in New Zealand. It can be done on men with a PSA level between 4 and 10 and has a higher sensitivity and specificity than PSA alone for determining whether prostate cancer may be present or not. However, in my view, if a man has a PSA level between 4 and 10, I would be advocating that they should have an MRI scan of the prostate, which is a much more accurate and objective assessment of their risk of prostate cancer than the free PSA. So in my practice, I personally never order a free PSA. I guess that leads us on into imaging. So I'm going to hand over to Dr. Remy Lim to talk us through the imaging aspects of prostate cancer pathway.
Thanks, Andrew. All right, so when we come to talk about imaging of the prostate, in my mind, there is like gold standards for different scenario. So for the patient that we want to diagnose or find prostate cancer, really the gold standard for that, as Andrew had mentioned, is a prostate MRI. And these days in Auckland, I think most men would be getting a prostate MR before the biopsy, and this I think applies to both private and public sector patients. Andrew also mentioned ultrasound, and we've had a few referrals sometimes from GPs asking for ultrasound looking for cancer. It's not something that we do in New Zealand, therefore there's not really that skill set to be able to diagnose cancer accurately on ultrasound. Really, the ultrasound is just good for getting some estimation of the volume and looking at the bladder, for example, but in terms of diagnosing cancer or looking for cancer in the prostate gland because of elevated PSA, we often will return these referrals and say, hey, probably MR will be better, but if they can't refer for MR, then the GP might want to refer to urologist instead and get the workup that way. So I generally discourage using ultrasound to look for cancer. Once we have a diagnosis of cancer, if the patient hasn't had a prostate MRI before the biopsy, then they would often get a prostate MRI to stage that cancer. And that's for various reasons. So if you see this series of sequences here on the prostate MR, what we're looking at are basically different ways of imaging the prostate gland. The top two images here are what we call diffusion-weighted imaging. And that basically measures the relative movement of water. So as you can imagine, the cancer is tightly packed cells, therefore the water doesn't tend to move freely. And that shows up on this sequence here as a bright signal here. That's the example of a cancer in the left side of the prostate gland posteriorly. And there it is there on the T2. So the T2 weighted image gives us the actual anatomical information. And we also do what we call dynamic contrast enhanced scan, which shows early enhancement of the cancer. So this is what we call a multi-parametric MRI. It's involved multiple parameters that we apply to the prostate cancer to give us a combination of information that would eventually result in some sort of diagnosis or a score. And then if the prostate cancer is known to be unfavorable risk or high risk, then PSMA PET-CT would also be the gold standard in terms of staging nodal disease or distant metastatic disease. And in the scenario where you have to restage a patient because PSA has recurred after treatment, then again, it's back to prostate MRI. And in the patients who've had prostatectomy, then the prostate MRI is crucial for us to do this dynamic contrast enhanced sequence. Overseas, there's a move to moving just to biparametric MRI, i.e. doing diffusion in T2 and skipping out the diffusion, the dynamic contrast enhanced. That's got some merits in it, but I still prefer to have this extra sequence here just for that certainty about whether there is or there is not a cancer. And likewise, for restaging of recurrence, PSMA PET-CT is also very useful. So I'll show you some images. So why do we do MRI pre-biopsy? Well, essentially, it's a roadmap for sometimes quite difficult lesions. And these lesions may not actually be palpable to the finger if you were to do a digital rectal exam. Ideally, you want to do the MRI on a 3T magnet because a higher field strength for the MRI means you get a better resolution of the prostate gland, which is not a particularly big organ. And that's why higher field strength gives you better resolution. So in the case of this cancer here, this lesion is actually located at the anterior aspect of the prostate gland. So you imagine having the finger examining the back part of the prostate gland, you're not going to be able to feel this lesion. So this is a difficult lesion to feel, in fact, probably impalpable. And yet, we need to tell the urologist that, well, you have to target this lesion because it's showing up as a probable cancer here. Another reason to do a prostate MR before the biopsy is actually can save the men from a biopsy full stop. And in fact, the earlier trial, Promise and Precision, both show that by doing a MRI of the prostate gland in the setting of elevated PSA, you could potentially save about 25% of men from a biopsy. If we don't find a clinically significant lesion and the PSA density is not too high, then potentially that man can be saved from having an invasive procedure. It also reduces overdiagnosis, particularly of the low-grade disease that we don't really want to go and overtreat, as Andrew had mentioned before. So it's quite lucky, and I suppose for us, that low-grade disease tend to be quite occult on MRI, and we tend to pick up more the higher-grade disease where the cells are tightly packed, and therefore it shows up more clearly, and then we see it on the MR, and then therefore we report it. So it's kind of good that we almost ignore the low-grade stuff or low-volume stuff because they just don't show up on the MR. Another reason to do the MR is to stage the disease locally. So that's us looking at extracapsular extension, whether it's gone to the neurovascular bundle, or whether there's seminal vesicle invasion as well. And that can affect how the patient is treated or whether surgery is possible or not. So if you ever come across a prostate MRI report, there will be generally a reference to a PIRATE score. That is a gold standard these days for reporting prostate MR. And PIRATE score essentially is a Likert score. It's a five-point scale that tells you how likely that the prostate gland has a cancer within it. So PIRATES 1 and 2, you can essentially ignore. There's really nothing there. PIRATES 2 will be like benign prostatic hyperplasia, BPH. That will get a PIRATES 2. PIRATES 1, I hardly ever report PIRATES 1 because essentially it's a normal gland. And generally men who come for prostate MR, they'll be over 50. There will be some abnormalities in it, like fibrosis or a bit of inflammation. So I virtually never give out a PIRATES 1 score. PIRATES 3, that's us sitting on the fence, and we're kind of quite good at sitting on the fence sometimes. It's frustrating, but sometimes all the parameters, as you can see here, that we look at, i.e. what it looks like in the peripheral zone and how much diffusion restriction there is, how strong the signal is there or is there not dynamic enhancement, and also what it looks like on the T2 for transition zone. They all equate to some grading of the abnormality there. But if we don't really get all the features to qualify for a PIRATES 4 or PIRATES 5, then they kind of tend to fall into PIRATES 3. So PIRATES 3 will be someone with inflammation or focal prostatitis. They often will get a PIRATES 3 because it can sometimes look a little bit like a cancer and low-grade cancer. So at the same time, focal inflammation can look just like that. So we end up with a PIRATES 3 scenario. But essentially, if we have a PIRATES 3, 4, or 5 on our report, that would pretty much trigger a need for a biopsy from the urologist's point of view. And Andrew can probably talk a little bit more about that. And we also heard about PSA density. So it's quite a nice correlation between PIRATE score. This is 3 or less, 4 and 5. And if you correlate that with PSA density cutoff of about 0.15, you can see there's a nice direct correlation of detection of clinically significant prostate cancer. So in terms of PET-CT or PSMA PET-CT, PSMA stands for prostate-specific membrane antigen. Essentially, what we're looking for are these, even though it's prostate-specific, there are other organ systems that also express this protein here called PSMA. But what we do is we label some form of positron emitter, in this case, a gallium-68, with a counterpart of this protein. And when we inject that into the patient's bloodstream, it seeks out these PSMA receptors, and where it's attached to in great concentration, as in prostate cancer, then the radioactivity is detected by our PET-CT camera. So that's how we kind of localize whether there is nodal disease or distant metastatic disease in patients with high-risk prostate cancer. Here's an example of a patient who had MRI. You can see this is diffusion weighted imaging. High signal there on the right side of the prostate gland, so that's very suspicious. Very nice correlation with PSMA PET-CT showing radioactivity or high expression of PSMA. About 90% of prostate cancer will have a relatively high expression of PSMA, so we can see them on PSMA PET-CT. That also means about 10 to 15% of patients will not have a high level of PSMA expression, and those cancers potentially may be occult on PSMA PET-CT as well. So it's not 100% accurate test. Here's another example of what is possible with PSMA PET-CT. So this urinary bladder that's bright because we've given contrast beforehand, so it's excreted intravenous contrast. That's a rectum there, mesorectal fat here. That's a hip joint on both sides. Watch this node here. There's a left internodiliac node. Normally, we would probably have to pass that node because it's not 10 millimeter in short axis dimension. But when we overlay that PSMA PET information onto this, even though this node may be 5 or 6 millimeter, we are very confident in saying this is a metastatic node here in the left internodiliac region. That's excretion of the radioactivity into the bladder. That's why the bladder looks red hot here. Likewise, if you have bone lesions, so for example, this case here where there's a sclerotic bone lesions, looks suspicious, but then again, bone island can also be sclerotic. But once you have the PSMA PET information overlaid onto it, then that becomes very easy for us to say, well, that's definitely prostate cancer and not a benign bone island. So it's good for staging both the primary sometimes, and good for staging nodes, and good for staging distant disease. There are scenarios though, it's not always showing up with activity. So here's an example of where MRI shows an obvious lesion here in the left side of the prostate gland posteriorly. You can see it here, diffusion restriction, high signal here, and then the nodule you see on the T2. There's avid early enhancement, which is characteristic of cancer. This is a full house of features that tells you that this is a PIRATS 4 or 5 lesion. And yet on the PSMA, there was absolutely nothing. So this patient will be one of those patients where there's that 10% that doesn't express PSMA receptors with their cancer. So that's a 1 to MR, 0 for PET. But it happens the other way too. So every now and then we get cases where MRI, which we did before biopsy, there was nothing there, but perhaps the PSA density is very high, and that still means that that's quite suspicious for disease, and the patient might have gone ahead for a biopsy. And if they came back with a positive biopsy and it's high risk, then they go on to the PSMA PET, and lo and behold, there's a lesion right there. Definitely no signal abnormality on the MR. It's not that we've missed it, but MR is not 100% either. MR sensitivity, specificity is around the low to mid 80%. It's also quite reader dependent as well. So here in a scenario where MR is 0, PSMA PET wins in this case. So I guess the point I'm trying to make there is MR and PSMA is quite complementary. PSMA PET will never overtake MR as the primary staging tool or diagnostic tool. Likewise, MR is good at picking up the primary. It's not 100% accurate. It's not that great to pick up nodal disease, especially if the nodes are still sub-centimeter or normal in appearance. So then we move on to the scenario if the patient had treatment and now we've got PSA recurrence. So more and more we are seeing quite a lot of disease being picked up, and sometimes very low volume early disease being picked up with PSMA PET. In this scenario, we would usually do an MRI of the prostate bed or of the native prostate if they've had radiation, and try and see whether there is local recurrence or not. Beyond that, we want to know whether it's spread to nodes or whether it's spread to distant sites. So that's where PSMA PET strength comes in. Here's an example of a patient with quite an odd pattern of spread. It's gone to the right supraclavicular node here and no other disease elsewhere. So in this scenario, it's really helpful for the radiation oncologist. Potentially, they could be targeting these 2 nodes here with just radiation therapy. And if PSA becomes undetectable again, then we know, well, that's clearly the solitary site of metastatic disease. And in that case, we can potentially delay patient from starting hormonal therapy or any other systemic treatment because there are morbidity and side effects associated with hormones as well. What we don't know, though, is whether this strategy necessarily will prolong patient survival. That data, I don't think is there right now, but it sort of intuitively makes sense. Like if you get the PSA to undetectable again by treating this solitary site of disease, then, you know, potentially they could be living longer, but we just don't have the data to prove it. Lastly, I'm going to finish quickly with a new treatment modality. And we do this in private for patients with metastatic prostate cancer. And I lost count of how many of the patients who come through. They say, I've mentioned this to my GP and they've never heard of it. So hopefully there's 370 people who joined in here. So hopefully I can spread it word to 370 GPs. And so they know what theranostics is. So theranostics is basically going from seeing to actually treating. We're pairing therapy with diagnostics. So we're trying to see whether the patient's prostate cancer highly expresses these protein. And then we use the fact that the proteins are present in great abundance to target with something that is radioactive and capable of cell killing. So we need to confirm expression of these little protein by doing the PSMA PET-CT again. So patients with no PSMA expression, they will not be able to be treated in this way. If they do express these proteins, then there is a potential for us to target. So we are currently doing this in a palliative setting. So patients with castrate resistant, they've had one line of chemotherapy, i.e. docetaxel, and they usually would have had hormones as well. So it's that sort of mid to end stage patients that we're treating a lot of. So essentially how it works is we swap out that gallium-68, the positron emitter, with something called lutetium-177. Other radioisotopes are now increasingly being used, but that's the original radioactive isotope, if you like, that's capable of breaking DNA strands. So we combine that with the counterpart protein, if you like, with lutetium-177. We swap out the gallium-68 for lutetium-177. Likewise, we just inject the lutetium PSMA into the patient's bloodstream, and it circulates in the bloodstream. And where there is PSMA expression, then you get attachment of the lutetium onto this protein. And lutetium-177 is a beta emitter, so it emits beta particles that then causes DNA strand breakages. And hopefully, if there's enough breakages in the DNA strand, then it causes cell kill. It's not 100% response rate. We're getting about a 50 to 60% response rate, which is what's been shown in the literature. But it is good in terms of prolonging patients' survival by quite a few months, similar to docetaxel, actually. And there's plenty of trials currently ongoing, trying to bring this form of treatment slightly earlier in the patient's journey, and perhaps combining it also with chemotherapy, or combining it also with some form of immunotherapy as well. So watch the space. I think you're going to hear more about theranostics. You're going to hear more about this form of radioactive, almost like liquid radiation. Basically, you inject the radiation into the patient's bloodstream. Here's an example of a patient I treated recently. Quite extensive disease. In February this year, all these red dots are basically bone mets, and there's some nodal mets here as well. This is liver and spleen. That they always look like that. That's physiological. Same with the kidneys. There's some bowel uptake as well. But you can see there's a big chunk of a bone metastasis here in the right pelvis. And quite surprisingly, this patient normally will give up to 6 cycles, anything from 4 to 6 cycles of treatment. But this patient responded so well that after 2 cycles of lutetium PSMA, pretty much all the metastases are gone, they're resolved. So, and that's nice also to see a concordant PSA graph here where the PSA was really shooting off. And first cycle delivered, just brought it right down. We gave another cycle and almost this was less than 1. It was about 0.3 from about 81. So in this case, we would stop, because now that we've basically killed off all the cancer cells, there is no longer any targets to target. So we would stop there and then just use PSA to follow up. It will recur for sure. And but if it does recur, then we have the option of treating them with more cycles of lutetium PSMA. This will happen probably in about 5–10%, where probably 5% or less, where after 2 cycles, it gets such a nice clean response. most patients will need about 4 to 6 cycles, and about 30 to 40% of patients actually don't even respond to it. So then they have to go on to second-line chemotherapy. Thank you. I'll pass on to Andrew.
Thanks for that, Remy. I'm just going to talk on where we go to sort of once Remy has identified the lesions to start with. Sorry. So we get to the point where Remy has a look with the MRI scans and find it. The one thing that I will just say, I just noticed in some of the questions, there's a few questions about digital rectal exam. I think just to clarify things, I think the data for digital rectal examinations is mixed, and it depends who's doing the digital rectal examinations. I think most of the trials have shown that digital rectal examinations looking for prostate cancer at a primary care level do not have a significant additional benefit. And so it really comes down to what you feel your skills are at identifying a prostate cancer. And it's not a case of, you know, whether you're any good or not, but it's just purely a volume thing. You know, I would feel 100 prostate cancers a year, so I know exactly what a prostate cancer feels like. So if I was looking for someone with prostate cancer, it would be remiss of me not to examine them. I think the difficulty is in primary care when you're seeing 1,000 people in a year and feeling 1,000 prostates and 1 or 2 of them has cancer, it's much more difficult to be definitive about it. And I think that's what Andrew Lienert was sort of saying, that, you know, if you could just do the PSA test, that's not an unreasonable approach either, because if they've got a raised PSA, we'll do an MRI scan on them, which is far more accurate than anyone's finger, really. So as Remy's talked about, the MRI now is our standard investigation looking for prostate cancer. And then it comes down to, well, if Remy can identify it on an MRI scan, what do we then do to actually find it? In the past, and in a lot of centres still, what we call transrectal biopsy was the standard of care. You can see a diagram of this here, and you can see what we essentially do is put an ultrasound through the back passage, and we put some local anesthetic there, and we take some needle samples. It is not an elegant way of investigating something. It is associated with significant risk of sepsis, and it requires antibiotic prophylaxis, and often people give iodine up the rectum to reduce the risk of infections. This is becoming an increasing issue because internationally we usually use fluoroquinolones for this, and people internationally are now having to use carbapenem and fosfomycin for prophylaxis in this situation, which is going to cause a lot of problems with resistance. It is starting to disappear internationally, but as I said, in New Zealand, it still is not infrequently done. And you can have a look on the left here. This is a diagram of actually what we do. It's transperineal biopsy is really internationally becoming the standard of care. Transperineal biopsy involves going through the skin. So on this diagram to the right here, this is the ultrasound going through the rectum. A grid is placed up against the skin, and the needles go through the skin into the prostate. This is some data that we have of Australia and New Zealand. It's a bit disappointing to see that New Zealand in 2021, only 20% of cancers were diagnosed on transperineal biopsy. And that puts us just above Northern Territory's rate and ACT, but well below rest of Australia, which is 80 to 90% of biopsies are being done through this method. As I said, it has a big advantage in essentially no risks of sepsis, and also antibiotic utilization is much better. So Remy's pointed out to us now how we can see these cancers. And on this diagram here, you can see this little yellow arrows showing a couple of areas of cancer here. What we can now do is we can actually fuse the MRI scan to an ultrasound. So this is, about 15 years ago when I was a fellow, we were developing a lot of this at the centre that I worked in, and it's incredibly difficult to actually get this fusion underway because when you put an ultrasound probe in the rectum, it deforms the prostate versus the MRI, but succeeded in creating this fusion software. And so what we can do is map this MRI onto the ultrasound, show us where the area of concern here, and this situation is in red, and we can actually label where the biopsies have gone. So we know that, for example, here that this green bit, which is the biopsy, has gone through the red area and also through here. So you can pretty reliably tell that you've done a biopsy now. We then, if we find the cancer, we go on to the staging situation. And PET PSMA scanning is without a doubt now the standard of care. It has taken a while to catch on in the United States because of politics and funding, but it is now booming over there. It is very sensitive and specific for prostate cancer. And I think that as sort of you're probably thinking when you're looking at that thing with Remy there, if you can fuse that MRI scan with that PET scan, that would be a great move forward. And people are doing that already. And I think with time, it's going to be a fusion scan that tells us where there's prostate cancer there. And we may even be able to avoid sort of even more unnecessary biopsies. The main reason to do it is to make sure that we're doing the right thing. So if somebody has prostate cancer and you're thinking of doing surgery on them, there's very little evidence to say that taking out someone's prostate is a good idea if they've got metastatic cancer. For that reason, we now have funding for these scans nationwide. Some centres are struggling for capacity issues, but it is funded nationwide. But it is important to know that people with low-risk cancers do not need to have these scans. So it always pains me when I hear that people have stumped up cash to pay for these scans out of their own pockets when they haven't actually qualified for funding for it. The reason why they don't qualify for funding is it's unnecessary test because of features like they have a low risk cancer, low PSA, pretty normal looking MRI scan. You can tell them that they're not going to have metastatic disease, and it's not worthwhile doing that scan. So that sort of allows us to start making treatment decisions. So, you know, highlighting the advantage of these scans, the Prostate Cancer Foundation, and this is back in 2019, funded a study where we actually looked at doing these scans and to see whether it would actually save us money by avoiding unnecessary surgery. And 1 in 7 patients undergoing the scan avoided unnecessary surgery. Probably the best thing to come out of this was that myself down here, Andrew Williams, got promoted to being a radiologist, as did Madhu Koya, became a radiologist as well. So, you know, you can see through this is all getting really complex here. You know, we're talking about seeing a patient, getting an MRI done, getting a biopsy done, fusing it, then staging them. And it's becoming increasingly heavy in terms of the radiology utilization and the coordination of it. And it is not uncommon for these patients to wait 6 to 9 months during this diagnosis. We know that patients get a lot of anxiety and depression during this period. And in fact, there's some evidence to say that suicide rates are increased when patients being investigated. And so to work this out quickly is in everyone's best interests. That's why we've got what Lenny suggested, which we're trialing this thing with Southern Cross. It's taken us about 3 years to get this over the board, but basically they're funding a speedy trial. A speedy prostate diagnosis trial. And this is to the point that we actually will do these biopsies in Auckland and we send them to, I think it's Tauranga, for the biopsies to be read, because it's one of the few pathology centres that can get us the results in days rather than weeks. We can often be waiting 3 weeks to get the biopsy results back. So the bottom there, the average pathway between 1 to 4 months is, I think, quite conservative. I think there's not a lot that would be less than about 2 months, but some patients can wait up to 9 months for a diagnosis. So we can see that, so any Southern Cross patients currently getting access to this pathway, I'd be very hopeful that once we show this proof of concept, that we'll be able to expand this to not only insured patients, but public hospital patients too. Because a lot of what we're doing with this is just actually organising things efficiently. There's not more work involved in it. We're really aiming just to show how us at the Urology Institute can work with Mercy Radiology. We can work with pathology providers. We've employed a nurse specialist to get involved in this and coordinate things. And that by doing that, we can actually make everything more accurate and efficient and support the patients through it to minimise the morbidity of investigation. So then once we've got that diagnosis, we've talked all about this, then how can we help patients decide what they're going to do about treatment? Prostate cancer treatment is very complicated. And one of the issues is that we often refer to international data on how good our different treatment options are and what our side effects of our treatments are. We often trust on clinicians to self-report outcomes. And, you know, as a surgeon, I know that I always have a rose-tinted view of the outcome of my patients. And so we need some way of actually working out, you know, if these patients are making a fair decision on what treatment they're going to undergo, what are the outcomes of the different treatments? So one of the projects that's been underway over the last few years is this PCOR database. So at the moment, 50% of people being diagnosed with prostate cancer in Australia or New Zealand have been entered into this database. It's funded by Movember, and it gives us accurate local data on patient outcomes and treatment trends. So not only are we knowing what the outcomes of our treatments are, but we're also looking at what treatments people are getting. One of the numbers that I think Australia and New Zealand can be quite proud of is this is the treatment of cancers in the low risk group. And you can see we see treatment of low risk prostate cancer as being a bad outcome if they're undergoing treatment, because the vast majority of low-risk prostate cancer should undergo observation and should not have active treatment. You can see we've had a steady reduction in the number of patients having treatment, and the blues here are the patients undergoing treatment for prostate cancer, to the point now that 80% of patients with low-risk prostate cancer are not having treatment, and that is one of the best from any sort of country internationally. This is Australasian data, and the New Zealand data is actually much better than that 80%, which is all good for us to see. The other thing that we can get out of this is we can see where our patients get their side effects and what their outcomes are. And these are patient-reported side effects, not clinician-reported side effects. I never see any of their reports of any of these. I never do any of these reports on sexual function, urinary function, and bowel function. These are just sent directly to the patients. And as I said, it's interesting to watch, because we have traditionally always said that your surgery knocks around the waterworks more, and radiation knocks the bowels around more. But in fact, the Australasian data has shown that radiation actually has knocked around the urinary symptoms more in our cohort. There is some evidence to say that actually sexual outcomes were knocked around more by surgery, which has not traditionally been reported as well. So it's good data to have a look at what you're doing locally. We get a copy of all these sent to us as individuals as well as our units. Here's another thing that's also we don't really appreciate so much when we're talking about prostate cancer treatment. These are the symptoms in the observation group. And one of the important things is to look at sexual function. This is the score basically on the left here is poor function, and on the right is highly functioning sexual function. And you can see here that there are a lot of people down on the left that have quite poor sexual function even before treatment. There is also quite a spread in terms of people's urinary function and bowel function, and interestingly also their hormonal function. So these are people who are not giving hormones that are getting symptoms of hormone replacement treatment. We can also compare this across different modalities here. And so this is observation, androgen deprivation, chemo, radiation, and androgen deprivation, radiation, and surgeries. This all helps our patients make a decision. And as this data set grows, we'll have stronger and stronger information to feed back to them. As I said, this is looking here at sexual function. As you see, not a big difference between the two. Hormonal function here with radiation is much broader, but it's always very interesting to know that we don't hear much about these people that do really well at the top. It's all the people at the bottom that are upset. And it's important to note that there's quite a lot here that this line's thickened up here that are getting sexual dysfunction following treatment. I'll pass things on to Lenny now, Andrew Lienert, who's going to have a talk about these outcomes.
It's obviously important that once we've treated men that we look after them afterwards. And the two main morbidities that we see, as Andrew just alluded to, are urinary dysfunction, particularly incontinence, and sexual dysfunction. I'm a surgeon, so I'm speaking really purely about post-surgical complications rather than necessarily post-radiation. In terms of managing incontinence after surgery, I actually think one of the keys is trying to prevent it in the first place. If we don't cause the incontinence, then we don't have to manage it. And part of that is patient selection. We know that older men are more likely to suffer incontinence after surgery. It was previously thought that obesity was a risk factor, but actually a couple of recent meta-analyses suggest that actually there's no difference in continence outcomes for obese men versus non-obese men. Comorbidity definitely increases risk of incontinence. There's a measurement called membranous urethral length, which is essentially measuring how much urethra there is running through the pelvic floor or running through the external urethral sphincter. Perhaps unsurprisingly, the longer the length of urethra that's surrounded by sphincter muscle, the more likely men are to be continent afterwards. And we can measure that on an MRI scan preoperatively. And prostate volume, which we can also measure fairly accurately on an MRI, the larger the prostate, the more likely they are to have incontinence. And so looking at those things preoperatively can help with risk stratification and counselling patients before they have surgery. There are factors during the operation that can influence the continence outcomes. I've put a number of different techniques that have been studied. As you'll see, most of them result in sparing something. Rather than going into the details of it, essentially with modern techniques and modern understanding of the anatomy and how some of these structures affect the continence mechanisms, there have been a number of different technical aspects to the surgery that have resulted in much better outcomes from a continence point of view. Surgeon experience and surgeon volume influence outcomes. If you look at the outcomes from extremely high volume centres, these are centres with surgeons who are literally only doing prostate cancer surgery, they will have better outcomes than a more general urologist who is working across a broad range of conditions and therefore doing less volume of surgery. Surgical technique and its influence on morbidity is something that's debated at length, particularly whether robotic surgery improves outcomes versus open surgery. From my take on the literature, if you look at the published series from very high volume centres, so surgeons doing several hundred cases a year, which technique they use probably has little influence on the outcomes because they all get such very good outcomes. But in surgeons with low or moderate volumes, which is really where New Zealand urology prostate cancer surgeons sit, the literature would suggest that robotic surgery does improve outcomes over open surgery in those lower volume centres. Pelvic floor muscle training has good data to show that it helps, and this should be started preoperatively and continued postoperatively, and works best if it's done in conjunction with a pelvic floor physiotherapist to ensure that patients are doing the correct technique, and also to give them good motivation to keep at the exercises. Medication can be used, in particular either selective serotonin reuptake inhibitors or anticholinergic medications. And these work mainly in the early postoperative period. And it's probably a reflection that a lot of early incontinence is not so much due to sphincter deficiency, but either pre-existing bladder overactivity or bladder overactivity induced by the surgery and the inflammation around the bladder. Alpha blockers are interesting. For some men, continuing the alpha blocker will have an adverse effect on continence because it relaxes the muscles. But there are some men where the bladder relaxing effect of an alpha blocker will actually help their incontinence. In my practice, I always stop the alpha blocker because I think in general it's more likely to hinder continence rather than help. For the majority of men, incontinence resolves following prostate cancer surgery. In modern surgical series, a around 30 to 50% of men will actually be completely continent from the outset. So from the time the catheter comes out of surgery, after surgery, which is around 7 to 10 days, they won't actually require any continence products and really won't have much in the way of urinary issues. For the rest, for the majority, it will resolve within the first 3 months. And we know that the longer time goes on, the more likely it is that it will resolve spontaneously. And so we wouldn't look to intervene in incontinence generally till at least 6 to 12 months post-operatively. Based on New Zealand data, we know that around about 5% of men post-prostate cancer surgery, however, will seek further surgical treatment for their incontinence. There are various options for managing it if it doesn't resolve. There are a number of men who will choose just to continue a conservative pathway. For them, it may just be very low volume, infrequent incontinence, and they're happy managing that either with pads when they're perhaps doing something, an activity that they know might cause the incontinence, or perhaps it's so low volume that they actually don't need to utilize anything. Penile clamps, these are just simple devices that in essence look like a giant safety pin with foam rubber on either limb, and you can clip the clamp over the penis, and it compresses the urethra externally to provide continence. This can be really useful in the short term after surgery for men that are finding the early incontinence really bothersome. They can be a little bit problematic long term with discomfort, skin issues, and atrophy of the penile tissues. I do, however, have a handful of men who utilize them longer term and just wear them perhaps if they're wanting to go out to a social occasion or somewhere where continence is more important for them. Bulking agents involve injecting various things around the urethra to provide compression to assist the sphincter function. These can work well in the short term, but often the effect wears off with time. Urethral slings are not dissimilar to female slings in the type of material and the insertion method. However, because of the significant differences in anatomy, we haven't seen the major issues that there have been with female slings. And many of you may be aware that female slings were removed from insertion in New Zealand for a short period due to those concerns and the implementation of a credentialing process. That's not the case for male urethral slings. We don't see the urethral erosions and various other things that that we've seen with the female slings. These slings work very well for men with relatively low level incontinence, perhaps using 1 or 2 pads a day, but don't work so well for men with more severe incontinence. For men with severe incontinence, an artificial sphincter device is likely to be the best solution for them. This is a mechanical device that has a cuff that sits around the urethra. The cuff is attached to a pump that sits in the scrotum. And the cuff is inflated most of the time and compresses the urethra to provide continence. When the man wants to void, he presses the pump a couple of times. That deflates the cuff. He can void, and then the cuff will naturally refill over a minute or two. These work very well in attaining continence, but because it's a mechanical device, there is a reasonably significant rate of 1 or more components failing and the need for revision over the first 10 years or so. The point really is that if men are significantly bothered by incontinence, they don't have to put up with it. There are options for managing it. And I see a number of men who have been really bothered by incontinence and had no awareness that something could be done about it. So if you have any patients like that, your urologist should be happy to see them and talk them through the options. For erectile dysfunction, again, if we can avoid it as much as possible, that's always best. We know that patient factors have a significant influence on the risk of post-operative erectile dysfunction. The younger the man, the more likely we are to preserve erectile dysfunction, erection function. And obviously, if they have pre-existing dysfunction, surgery is certainly not going to help that. And that can be determined using a validated questionnaire called the IEF questionnaire. There are surgical factors. Nerve sparing refers to preserving a tiny meshwork of nerves that run close to the posterolateral surface of the prostate. So skinning right along the margin of the prostate with the aim of trying to minimize or completely avoid disruption of that nerve plexus. That nerve plexus carries on down past the prostate to the penis and is an important part of the erection mechanism. And there is data to show that robotic surgery improves outcomes from an erectile function point of view. In terms of rates of erectile dysfunction, I think the data that Andrew showed is very useful, because that is New Zealand data based on a large proportion of the population of men who have undergone treatment in New Zealand. And the reported rates in the literature vary a lot, and I think that's partly based on how you define the dysfunction, and also what the patient population's pre-existing function, age, and so on was in those studies. There are things that we can do afterwards to try and maximize the chance of erection function returning after surgery. I should say that virtually all men in the immediate period after surgery will be unable to obtain an erection. And so really, when we're talking about preserving erection function, we're really talking about the proportion of men where erection function returns. And it can return anywhere up to 2 years after surgery, so it can be quite a long period of recovery. There are lifestyle factors, so regular exercise and keeping healthy definitely helps. Obviously, not smoking and minimizing alcohol intake also help. There's strong data to show that PDE5 inhibitors are useful and that they should be started early in the post-operative period. And also that they should be on continuous rather than as required treatment. In this setting, the PDE5 inhibitors work by increasing the blood flow to the penile tissues, which helps with the healing and restoration of those tissues. So in my practice, we generally will see a man back at 6 weeks for a second visit post-op. That's done so that we can do their first PSA test at that time. But when I see them for that 6-week visit, I will generally start them on tadalafil. Most of you may know it as Cialis, although it's off label now, and there are a number of alternatives available. And I start them on 10 milligrams every second day, because the half-life of tadalafil is around 36 hours, so they don't need to take it daily. This gives good continuous dosing, and because it's every second day, it works out a little bit less expensive than giving daily treatment. Sildenafil, the most famous version of that was Viagra, but again, there are a number of alternatives around. It has a half-life of about 6 hours, so in my opinion, isn't as useful in this setting as a longer-acting PDE5 inhibitor. In conjunction with PDE5 inhibitors, it's important that men use it or lose it, so to speak. What I mean by that is that they need to create an artificial erection periodically. If the penile tissues are left dormant, there is blood sitting in the corpora cavernosa that will clot. It will also cause inflammation, and they'll develop fibrosis in the penile tissues. And so if it's left dormant for too long, then simply the probability of return of natural erection function is significantly lower. There are 2 ways of creating artificial erections: either intracavernosal injections, so these are direct injections through the lateral side of the penis into the corpora cavernosa, and there are 3 different drugs that can be used, or they can be used in combination. We do this in our practice through a nurse specialist clinic. She sees the patients, talks them through how the injections are done, and will also work out the right dosing regime for them, because early on it's important to get the dose right. It's not the same dose for every man, and what you want is a dose that's enough to create a suitable sufficient erection, but not such a big dose that lasts for hours. And that is one of the risks of intracavernosal injections, is causing a priapism, which is a abnormally sustained erection. If the erection is sustained for too long, there's ischemia of the tissues in the penis from the pressure, and that will actually make the dysfunction worse rather than better. So important that this is a process that's overseen in the early period. Once men are established on the injections, generally they will be able to stay on the same dose. They'll be able to have the medication at home to use as and when required. I recommend to them that they create an artificial erection at least once a month, but ideally more frequently than that. The alternative way is a vacuum-assisted device. This is a cylindrical device that's placed over the penis and creates a seal at the base of the penis. And then a vacuum is created within the cylinder, and that suctions the blood into the penis to create an erection. If the men are not planning to utilize the erection, they can simply take the device off and the blood will flow back out again. If they do wish to utilize it, they need to leave a ring at the base of the penis so that the erection is sustained. Obviously, it's important that they take the ring off after they've finished. Otherwise, it can be a little bit like tailing a lamb. And finally, there is a penile prosthesis. There are two groups of men for whom this may be considered. There's a group of men who undergo prostate cancer surgery for whom there is no likelihood or hope of return of natural erection function. Perhaps they had poor erection function preoperatively. Perhaps they had a high-grade, high-stage cancer, and so a very wide resection was done. And for those men, a discussion can be had early on around implanting one of these devices. Or the other group will be men who are a year or two down the line, and unfortunately there has been no return of spontaneous function, and they're not finding intracavernosal injections or the vacuum-assisted devices are working well for them. It's a mechanical device. There's two cylindrical balloons that are implanted into the lumen of the corpora cavernosa, and those balloons are attached to a pump that sits in the scrotum, and that pump's attached to a reservoir. For the majority of the time, these cylindrical balloons in the corpora cavernosa are deflated and the penis is flaccid. When the man wants an erection, he squeezes the pump a couple of times. That pumps fluid from the reservoir into those cylindrical balloons, creating an erection. Again, like the artificial sphincter device, they do work fairly well, but being a mechanical device, there is a risk of mechanical failure, and therefore needing to revise one or more parts of the device. Thank you.
Fantastic. Thanks so much, Andrew and Remy, and Andrew, for all sharing your expertise and excellent updates tonight. But I did want to bring up, because there has been a number of questions, and maybe for you, Andrew Williams has answered a whole lot of them around the PSA level testing, or Andrew Lienert, whoever wants to answer this, around the different cutoffs that we are seeing around the country. And specifically, there was a question around that, Andrew, you answered around the predictive lifetime risk of prostate cancer when you do it in your age of 40, in your 40s.
Yeah, I can probably talk about the cutoffs. The cutoffs, it's honestly, it was like I was involved in the second round looking at this about 10 years ago, and it was like herding cats, get everyone to agree. The first off level of 4 was basically decided because there's a lot of controversy in terms of what the lowest threshold is for for being investigations. You probably could move it lower, but the lower you move it, the more problems that you cause and false positives that you get. There's no real evidence to say that catching a cancer earlier than a PSA of 4 has any benefit in terms of their chances of cure. If their PSA is 5 on diagnosis, they're still in a really high chance of cure. The second lot is when you get to the PSA of 10 is a bit more controversial, because once you start getting into the 70s, you're looking at an early prostate cancer is likely to outlive the patient. So in your early 70s, you're starting to talk about, well, hey, if I find the cancer, I'm going to cause more harm than good. And that's when that PSA of 10 came in. That's a little bit more arbitrary. And the PSA of 20, when they hit 75, is in there because there's no real strong evidence to say that local treatment of prostate cancer improves life expectancy in the over 75s. Now, if people read the document, there are a bunch of caveats put in there, which people don't often mention. And the biggest one is rate of change of the PSA. If you're worried about the rate of change of the PSA, that's a good reason to refer. And it would be a very brave urologist that would decline a referral from a GP who's worried about the rate of change of a PSA. Likewise, prostate examination starts coming into it, because if you feel anything abnormal on the prostate, regardless of PSA, they should be referred. So even if the PSA is 3, but you feel it feels firm, they should be referred. And so to a degree, it is fudging the system a little bit, you know what I mean, with those bits. But it was basically to try to get agreement from everybody.
Just on that, I mean, one of the difficult things with rate of change is I've never seen a consistent definition of when to worry about it. And also it's common to see PSA levels fluctuate up and down. So it is a really grey area, and I don't think there's a single answer that can define what rate of change you should be worried about. I certainly think, you know, a persistent PSA rise, so on more than one test of greater than 50% over a year, I definitely think should be investigated, and that will be kind of my rule of thumb. I don't know whether you had any thoughts, Andrew.
I say doubling in a year, but I think if you're worried, pass the buck. So, you know, you may get a letter back saying, actually, we've looked at the kinetics and we're not too worried about it, but then it's not your problem. You know, you've had some advice and they'll give you they'll tell you what they expect.
I lost my train of thought. Never mind. There was a couple of questions about referrals in through the e-referral system, and the e-referral system is sort of structured to be black and white, and so I don't have an answer for those questions other than to say I'll take that back as feedback that they need to think about how do you incorporate an abnormal DRE and a normal PSA into a referral, because at the moment, as I understand, you can't get past the wall of, hey, the PSA is normal. That's, you know, we're not seeing it. So I will feed that back to the group that set those up. There's a question around ACC covering incontinence. Yes, definitely. So ACC will cover post-prostatectomy incontinence work. So definitely worth putting in ACC for that. The erectile dysfunction one's interesting. I have had a couple of patients that somehow have had ACC approval for that, but then I got rather excited and subsequently put in a few ACC reports that then got declined. So I'm not exactly sure where ACC sits on that. Do you know, Andrew?
No, I think they will fund it in exceptional circumstances, like someone in their 40s who basically who has perfect erectile function beforehand, but it seems to be a bit random at the moment. One of the things that I was just going to mention there is there's a question there about PSAs post-radical prostatectomy. So if your prostate is removed, technically your PSA should be 0. It is not uncommon to have very low but detectable levels, but I think it would be quite reasonable as a GP to say that if a PSA is detectable post-radical prostatectomy, to put in a referral that the urologist should know about it. The reason for that is that if you'd offer what's called salvage treatment, which is giving radiation to around where the prostate was, you do want to know about it, and you certainly want to know about it before it gets to 0.20. But we would often, if somebody's got a detectable PSA post radical prostatectomy, keep a close eye on that for whether we would give that secondary treatment.
Yeah, it's another just a good point around that, because in the lab test reporting, they don't necessarily know the patient's had a prostatectomy. And so the test will come up looking like it's normal. And it's a bit tricky, because I know what it's like going through your inbox of 1,000 tests. You tend to just tick off the normal ones quickly. But yeah, it's one that you can get caught out on, because post-prostatectomy, it should be 0 theoretically.
Brilliant. Thanks, guys. And I know, Remy, you've done a wealth of answering a bunch of questions again through the Q&A section. Was there anything in particular you wanted to briefly bring up in the last couple of minutes?
But with regards to that biochemical recurrence, you know, we've certainly seen at PSA, really low PSA level of 0.2, being able to pick up the site of recurrence, actually. So, and that offers the opportunity for radiation oncologists potentially target that particular site of disease instead of instituting hormonal treatment, you know, as the example I gave earlier.
I just saw a comment pop up that ACC don't accept claims for incontinence. They definitely do post-prostatectomy. As the urologist writing the treatment injury claim, you're right, we do have to write that there's a physical injury to the sphincter, but it is covered.
Yeah, I'd agree with Lenny on that. And interestingly, someone's mentioned about ACC and firemen. Yeah, I've noticed that too, that they will cover firemen who develop prostate cancer. Is
there a particular basis to that? Do we know?
Apparently, it's to do with the inhalation of the chemicals that firemen go through. They have a markedly increased risk of prostate cancer. We're not quite sure why, but it's accepted by ACC as being fact. So.
It sounds like a perfect study coming up for someone who's interested in occupational risk, prostate cancer risk. Look, thanks, guys. We could keep going on forever, because I think you're just a wealth of information. And thank you again for sharing all your expertise and answering all the questions and going through a great variety of topics. We really appreciate it. And thanks again, Andrew and Remy.
Thank you.
No problem. Thank you.
Good evening.